Dear friends, today we'll discuss about a novel agent that is imeglimin and how it is important for treating type 2 diabetes. So for next maybe 15 to 20 minutes, we'll discuss about this broad agenda. First of all, we need to understand the mitochondrial dysfunction in type 2 diabetes and then how imeglimin that can address dual effects while treating our type 2 diabetes patient. Also, we will try to dissect few data that is from the Times program, the efficacy and safety analysis. Then we'll talk about some prescribing considerations on imeglimin. So we know from our class 8 days, the mitochondria is the powerhouse of the cell. And we know that mitochondria was not initially inside our eukaryotic cell. So it was something prokaryotic in nature, which came inside us, inside our cell, and then become ours. Initially, they have a symbiotic relationship with the mother cell or host cell. Then they have integrated into the cell. They lost more than 90 to 98% of their genes. But important to note, today the mitochondrial DNA and the nuclear DNA, they are separate. And that is the very important evidence that suggests it is not from the very beginning the mitochondria was there inside us. So when it enters inside us, it becomes the powerhouse. And a very important structure in mitochondria, that is the cristae, which also increase the surface area overall, and that is the place of electron transport chain. So enhanced ATP production through oxidative phosphorylation, and that is cristae is the place where this happens. And this molecule we want to know, that is PGC1 alpha, because this is a potent coactivator of transcription factors, which has an important effect on whole body energy expenditure, including the TFAM and NRF2, which regulates gluconeogenesis, glycolysis, lipogenesis, paroxysmal and mitochondrial fatty acid oxidation, along with overall mitochondrial respiration efficiency is maintained by this molecule. And this is expressed in tissues with high energy oxidative capacity like heart, skeletal muscle, liver, brown adipose tissue, and brain. And generally, this is robustly induced in conditions requiring energy like cold, fasting, exercise. So, when there is insulin resistance and type 2 diabetes in skeletal muscle, the expression of PGC1 alpha reduced. And this diagram emphasizes the nutrient dependent at AMP ATP ratio and NAD plus NADH ratio, which is extremely crucial for AMPK and SIRT activation. And if there is proper activation of this AMPK SIRT1-2 pathway, there will be promotion of PGC1 alpha molecule, and that will help in optimal mitochondrial function along with biogenesis, which help in different types of tissue plasticity. Here, they are giving an evidence on neuronal plasticity. But when there is excess of nutrient, when there is nutrient independent loss of insulin, or we can say the insulin regulation will be decreased, the AMPK SIRT activity reduced, and ultimately that also decrease the PGC1 alpha, and therefore the mitochondrial function become aberrant, and the biogenesis, the natural biogenesis process will be impaired, which leads to suppression in the neuronal plasticity. And we know these steps that happen inside the cytoplasm of the cell, and the acetyl CoA, which is a very crucial thing that enters into the mitochondria, enters into the process that is citric acid cycle, and there will be NADH, FADH2 production. And this NADH, FADH2, these are very important molecule because they will be taken up by the electron transport chain, and that will cause release of ATP, and this whole process is known as oxidative phosphorylation. So when we are talking about electron transport chain, this is a very crucial system inside mitochondria which regulates ATP production, which if there is some impaired activity in this electron transport chain, some electron leakage happened. So therefore, that will associated with generation of reactive oxygen species formation, and that also promote apoptosis by production of cytochrome C expressions, expression of other pro-apoptotic molecules like casposes and etc. So this apoptosis will lead to imbalance in the mitochondrial environment. And when we talk about overall relationship between mitochondrial dysfunction and type 2 diabetes, we need to consider genetic factors like mutations in the mitochondrial DNA, nuclear DNA, and both, along with the environmental factors like obesity, excess eating, intrauterine malnutrition, other environmental pollutants, they all lead to mitochondrial dysfunction, which is associated with either beta cell dysfunction, like in case of beta cell, there will be beta cell failure, more apoptosis in the beta cell, impaired insulin secretion, and the mitochondrial journey of fusion, fission, autophagy that becomes abnormal. And when we talk about insulin resistance, as there is decrease in mitochondrial DNA, regulated oxidative phosphorylation, lesser expression of oxidative phosphorylation. So that will lead to long chain acyl CoA formation, more and more diacylglycerol and ceramide will be there. This all will lead to type 2 diabetes development. So when we talk about increased calorie consumption, therefore, our electron transport chain become overactive. And as they become overactive, later their function will be impaired. So depletion of antioxidant enzymes like superoxide dismutase is another important factors. So when we talk about impaired electron transport chain and reactive oxygen species formation, we need to know that more and more free radicals will be there, and that will lead to mitochondrial dysfunction and beta cell dysfunction along with apoptosis. So complex 1 of this electron transport chain is predominant site because there will be donation of electron to the oxygen will be, that process will be impaired, and more superoxide will be produced, and that superoxides that ultimately lead to formation of free ions, or sometimes copper ions transforms this hydrogen peroxide to highly active hydroxyl radicals. So in the skeletal muscle, again, as the expression of PGCA1 alpha will be reduced, decrease in oxidative capacity, more reactive oxygen species formation will be there. So more and more diacylglycerol and ceramide will be there. That will cause decrease in insulin resistance. And the normal process of the mitochondrial biogenesis, that will also be impaired. So proper mitophagy, which generally happens to remove the damaged mitochondria, that will not be there. So generally, the healthy mitochondria also be destroyed. And when we have some therapeutic options like proper dietary modifications, exercise, and some drugs. There are compelling evidence which suggest this will boost mitochondrial function. And if we can improve the mitochondrial function, that will associated with enhanced insulin sensitivity, increased insulin secretion, and that will address different types of complications. So as we were talking about two important challenges in type 2 diabetes management, we need to address beta cell dysfunction, number one, and number two, insulin resistance. So if we have something that can improve mitochondrial bioenergetics, that can help in both addressing this insulin secretion problem and high insulin resistance. So that balance will be maintained. And that if we can have molecules like imeglimin that can address this mitochondrial bioenergetics in liver, muscle, and pancreas. So this is in general the mechanism of action of imeglimin, which correct the defective complexes in the electron transport chain. Especially this will inhibit partially competitively the complex 1, which help in reducing the reactive oxygen species formation. Not only that, that also restores the complex 3 function. So properly electron will go to the complex 4, and that will help in maintaining the proton gradient. And if we have a proper proton gradient, so we will have a good oxidative phosphorylation. Not only that, as there will be lesser electron leak, so what happened? The cytochrome functions and cytochrome C mediated or Caspase mediated pro-apoptotic factors will be not playing their huge role. Then we can control those pro-apoptotic factors, and therefore we can prevent MPTP opening, so the pore will not be created, and lessen the release of other pro-apoptotic proteins. And as we had mentioned in beta cell 2, if we can increase the ATP generation, so therefore the glucose sensitive insulin secretion will be there. So that will increase the glucose dependent insulin secretion, prevent beta cell death, increase functional beta cell mass. And when we talk about addressing the insulin resistance, this will definitely enhance insulin action by reducing excessive gluconeogenesis, decreasing the steatosis, and in muscle, this will increase the insulin signaling, stimulates glucose uptake, properly helping the GLUT4 receptor to reach the surface and improve insulin entry. So glucose entry. So molecular mechanisms, these are important molecular mechanisms of imeglimin, which address insulin sensitivity, which decrease gluconeogenesis, improved beta cell function by decreasing beta cell death, apoptosis, increasing beta cell mass, mitochondrial function, overall efficiency in the oxidative phosphorylation will be more, reduction in the mitochondrial induced free radical generation. So imeglimin via the nicotinamide pathway, when they will produce that NAD+, so that will correct first the complex 1 in the electron transport chain, followed by there will be correction in the, or we can say improve efficiency in the class 3 of electron transport chain, and that will help in properly production of CD38 related pathways, and that will stimulates the intracellular lysosomal receptors like ryanodine receptors, which tells calcium to come out, and ultimately the insulin secretions will be there. So glucose sensitive insulin secretion will be there. So when we are using imeglimin, they will have a proper effect on mitochondrial energetics. They will address different pathology in liver, in pancreas, and in skeletal muscle, improving the overall glucose utilization. In liver, they will decrease the gluconeogenesis. And in pancreas, they will increase insulin secretion, along with they will reduce the beta cell apoptosis. So this provides a novel approach for the treatment of T2D due to its unique dual mode of action, both insulinotropic and insulin sensitizing properties. Now coming to different other complications that is associated with type 2 diabetes, and renal complication is very common. So this is a proposed mechanisms of mitochondria mediated renoprotection. Similarly, when we talk about the electron transport chain and the complex 1, the metformin, they also have an effect on that area. But along with that, imeglimin has an important role in the complex 3. Not only that, in the between the complex 2 and complex 3, there is a place where the cytochrome C and related apoptotic factors will come in the picture. So there also the imeglimin help in reducing those pro-apoptotic element production. So mitochondrial biogenesis and remodeling, these are important. And here we can say the imeglimin is the first in new class of oral antidiabetic drugs that can reduce reactive oxygen species production and also increase the mitochondrial DNA synthesis. So when we are talking about ameliorating the abnormal mitochondrial function and to reduce the reactive oxygen species formation in diabetic kidney disease, these are important mechanism of action, decreasing the reverse electron transport through complex 1. So the more proton will come out and that will create the proper electron gradient. Obviously, the reducing the activity of the complex 2, especially the focusing on that area of the cytochrome C and restoring the expression of subunit of complex 3. So decreasing the albuminuria and interstitial fibrosis had been seen in different mouse models. Now we all now talking about SGLT2 inhibitors and its role in heart failure. We know that there is a proposed mechanism that is improving the mitochondrial biogenesis. SGLT2 inhibitors also help in this heart failure ameliorating effects. Similarly, if we talk about imeglimin and its action on electron transport chain, they reduce the permeability transition proteins, protein pores that happen. So the pore will be less there. And therefore, if we can prevent those permeability transition pore, that will lead to less apoptosis, and that can improve the myocardial function. And also, we know the endothelial cell dysfunctions lead to myocardial ischemia, and that action, the NAD plus mediated pathways. So in that segment too, imeglimin has an important role. So when we talk about imeglimin actions in cardiac health, we need to acknowledge the mitochondrial function and cardiac health, especially the mitochondrial permeability and cell apoptosis decreases mitochondrial permeability transition pore opening. So this MPTP opening will be decreased by this imeglimin, which reduce the risk of cell apoptosis. Apart from that, in mice model, it had been seen that imeglimin produced some beneficial effect in heart failure with preserved ejection fraction, which is a classic characteristic of diabetic cardiomyopathy. By reducing inflammation, lipid peroxidation, improving the endothelial function, this molecule can give a good cardiac health. And in diabetic rats, it had been seen, it reverses the impaired left ventricular function, improves coronary relaxation, reduce the left ventricular reactive oxygen species production, independent of glucose levels. Now we know many molecules are there, like SGLT2 inhibitors. They produce cardiovascular benefit independent to the diabetic status. We don't know if we have future studies on this molecule, imeglimin. They also may produce some beneficial role in terms of cardiovascular outcome. But yes, we need to wait for the data. We need to have more clinical trial in this regard. So now let's see some efficacy and safety data of imeglimin. This is the times 1 trial where the imeglimin molecule was compared to placebo. So this was a double-blind randomized control trial, which had shown a 0.9% almost HbA1c reduction at 24 weeks compared to the placebo. And when we talk about secondary endpoint, the 35.8% of the patients reached less than 7%, whereas the placebo group reached only the 7.5%. And regarding the side effect, the gastrointestinal side disorders were the most common side effect. Along with that, there was a non-statistically significant increase in hypoglycemia with imeglimin molecule. Another times 2 trial where they had compared the safety and efficacy of imeglimins for 52 weeks as monotherapy or combination therapy with existing anti-diabetic agents. So this was a 52-week open-label multicenter trial where they had shown the primary endpoint. This produced only 3.7% of the cases there were hypoglycemia. So long-term combination therapy, the hypoglycemia was around 3.1 to 16.5% of the patient. No severe hypoglycemia was reported, and there was a greater number of hypoglycemic events if it is combined with the glycinide molecules or with the sulfonylureas. So no clinically significant changes in ECG, vital signs, physical examination, or lab test. The secondary endpoint that suggests that DP4 inhibitors, the combination with this imeglimin, there was almost 1% HbA1c reduction. On top of sulfonylurea, it has produced a 0.56% HbA1c reduction. So apart from the GLP-1 RA, all the other, on top of all the other existing oral anti-diabetic agents, this produce at per 0.5 to 0.9% HbA1c reduction. Now coming to the times 3, where this was actually a randomized double-blind parallel group trial where they had evaluated the efficacy and safety of imeglimin for 52 weeks with combination with insulin. So there, what they had found at 16 weeks, the HbA1c reduction on top of insulin was around 0.63%. And secondary outcome was there, the 7.4% of the patients, they had reached the less than 7% of HbA1c compared to the placebo group who had reached only 0.9%. So this was quite statistically significant. And here we can see how with time the HbA1c reduction was there up to 52 weeks. And that mechanism, within the 16th week, the reduction was robust. So it produced some early decrease in glycemic control was there. Now, a systematic review and meta-analysis, which had shown it produced 0.9% HbA1c reduction when they had used it 1,000 milligram twice daily. This was from 2 monotherapy studies, times 1 and Dubog et al. But when combining with times 3, this HbA1c also becomes like same, around 0.8% reduction. So generally, this systematic review and meta-analysis concluded with a reduction in HbA1c by imeglimin to the magnitude of 0.9% in monotherapy is at par with other agents which we used commonly as oral agents, and the pooled meta-analysis both as monotherapy or in combination that show a significant reduction in the HbA1c value, but only with on the arm, the times 2 had shown that when we are using it on top of GLP-1R agonist, the HbA1c reduction was not that significant. Maybe this is due to the long duration of diabetes in the GLP-1RA group, almost 11 years. And the people receiving this injectable GLP-1RA, they are typically those patients who have failed on the other oral agents also. And they have a limited ability. There is a limited ability by imeglimin to augment further insulin secretion. The adverse events are not that significant except those GI side effects. And apart from that, the lactic acidosis was not seen with imeglimin because the target in the electron transport chain is little different in imeglimin compared to the fenformin and metformin. And this is a difference between the metformin, fenformin, and imeglimin in the pharmacophore. So imeglimin distinct from metformin with its cyclic structure and this triazine ring. So we can see this benzene-like ring here. Along with this dimethyl group is same here, like metformin, but this benzene ring is a little bit difference in this imeglimin molecule. Generally, the pharmacokinetic characteristics suggest it should be given 1000 milligram twice daily, 12-hour interval, because the half-life is 13 hours. It is not metabolized, eliminate unchanged in the urine. There is no significant drug-drug adverse interactions or drug-food adverse interactions. But if EGFR is more than 45, we can use 1000 milligram twice daily. But between 15 to 45 ml per minute, we need to use it in reduced dose, 500 milligram twice daily. In the hepatic compromised patient, generally no dose adjustment is required up to mild to moderate according to the Child-Pugh score, but no studies done in severe hepatic impairments. Adverse events are like some inflammatory changes in the upper airway along with the gastrointestinal disturbances. So this has a very low protein binding, very low hepatic metabolism, urinary excretion of unchanged drug, and there is no QT toxicity. So QTc prolongation was not there in a very high dose. So inter-race pharmacokinetic difference was not observed when they were studied in Caucasians and Japanese patients. So in nutshell, if we should not use this drug, obviously in pregnancy, lactation, preconception, in childhood, there is no data that much. When the patient is having some intensive muscle exercise, we don't know what will be its actual effect, because that also have some effect in the mitochondrial health. So excessive alcohol intake, we should avoid this. And according to the EGFR, we need to change the dose. There is no data on patients who have severe hepatic dysfunction. Now, this concept is new. The Planck nanofibers, we can see in this diagram. This is the Planck nanofibers, and this is the imeglimin loaded nanofibers, which is very smooth. We can see no non-porous and non-beaded. So this is a concept when imeglimin loaded into electrospun nanofibers and delivered through the buccal cavity. So that gives some advantage in terms of reduced gastrointestinal adverse events. So ultimately, achieving the optimal therapeutic outcomes and improving patient compliance, this will be a futuristic idea. We need to wait for the clinical trial reports. So two challenges we have while treating our type 2 diabetic patient. Number one, the insulin resistance, and number two, the beta cell dysfunction. Imeglimin it has a unique action. It addresses both insulinotropic and insulin sensitizing properties. The clinical trial status are there, times programs which had shown times 1, times 2, times 3, significant efficacy and safety of this particular molecule. This has some distinct mechanism, offers advantages over existing type 2 diabetes medications, particularly addressing the mitochondrial health. But as this is a new molecule and very recently approved in India, we need to be watchful. We need to be vigilant in case of any other adverse drug reactions that appears. We need to do proper causality assessment, and we need to report those cases to the appropriate authority. In this case, we should report to the Pharmacovigilance Program of India, PVPI. We need to acknowledge the gastrointestinal side effects are there, just like metformin also. So mitochondria, we know we got mitochondria. The mitochondrial DNA is from our mother, and mother is something which is most important for us. Mother is respected in our country, and always when we worship our Lord Shiva, worship we Bhagavan Vishnu, we need to see them as Ardhanarishwar. So Shiva, Shiv and Shivani, Durga. So both of them are important, and Durga is the manifestation of power, dynamicity. So here also in our cell, the mother is mitochondria. The energy is from mitochondria. We need to take care of that organelles, that dynamic organelles. Otherwise, our dynamicity will be lost and we will be diseased. So take care of your mother, that is mitochondria. And for that, the drugs are there, but the simple tools like if we eat properly, if we exercise properly, our mitochondrial health will be maintained. So thank you. If you have any questions or comment, you can put in the chat box. Thank you very much.